Okay, I'm very glad to have this opportunity to share with you about our experience uh, regarding PBC surgery. Uh, and this is the agenda for my presentation today, including 9 parts. The emergence of PBC surgery had certain degree of accident. Uh, and in the 1950s, trigeminal neuralgia was believed to be caused by local adhesion and or compression of the trigeminal ganglion or its peripheral branches. The treatment at that time, including making an incision in the temporal region to perform local decompression, which is different from the current MVD. It was then discovered that if the facial numbness occurred postoperatively, pain relief tend to be satisfactory. Conversely, if no numbness was present, the outcome was usually poor. Then Shelton published his renowned article and compression rather than decompression for trigeminal neuralgia. And he pointed out that the therapeutic effect is not due to the decompression, but the damage to the nerve during the operation. Following this, decompression of the trigeminal ganglion was then replaced by rubbing, compressing the nerve. In 1978, Professor Mullen began experimenting with a percutaneous approach. The work of microballoon compression at our hospital dates back to 2016. Our first cases of PBC was performed on April 22, 2017. Since then, we have carried out a series of work, including a technical improvement and training for residents. And to date, we have performed more than 3,000 cases of PBC surgery. This was our very first cases. Okay. First of all, to perform this surgery successfully, we must have a thorough understanding of the relevant anatomy. We should identify the region where it's safe to conduct the procedure. As we can see, this is our targeted foramen up. There are many important structures surrounding it. Laterally is the spinous foramen, which contains the middle meningeal artery. Medially is the foramen lacerum, through which pass the internal carotid artery. Posteriorly, the carotid foramen and the jugular foramen. Anteriorly is the inferior orbital fissure. Viewed from above, Michael's cave is positioned posteriorly and medially to the foramen. The cavity is filled with cerebrospinal fluid connecting to the prepontine cistern through the trigeminal pars. Understanding this is crucial for increasing the success rate of the surgery. Right? So it requires that the puncture should be performed at an inward and backward angle, directing the tip of the needle towards the Michael's cave for a higher likelihood of successful penetration, right? And a head CT scan that includes the foramen is usually necessary. The primary purpose is to exclude intracranial space occupying lesions Then we need to know the size and the shape of the foramen. Three-dimensional reconstruction is preferable because sometimes the information obtained from a standard axial CT scan is not comprehensive. Looking at the patient on the right, the foramen appears to be of more moderate size on the CT scan, which seems acceptable. But when viewed from the when viewed in the sagittal and coronal planes, the lateral pterygoid sphenoid bone is highly developed, obstructing the foramen. In such situations, three-dimensional reconstruction can provide more information, especially for surgeons with less experience, right? The point this slide aims to illustrate is that the foramen is not only wise but also thickness in some individuals. As seen in the cases on the right, the foramen is very narrow and elongated, which may present certain difficulties during our surgical procedure. Following the administration of anesthesia, the next step is involve patient's positioning and the layout of the C-arm. The patient is positioned supine without the need of cervical hyperextension. As for the C-arm layout, the principle is to align it with the line connecting the external auditory meatus. Our practice as the surgeon stands and the patient's right side, regarding of whether it is left or right TN. The display screen placed in front for easy observation. Thus, under fluoroscopy, a standard lateral view of school was obtained. The requirement is that the bilateral external auditory meatus and the mandibular condyles should be overlapped. The overlapped external auditory meatus will appear brighter under X-ray. Right. The next step, we are going to prepare what we need for the operation. It is very simple. 2 packs of gauze, syringe, and iodopher for disinfection, saline solution, contrast agent, and most importantly, we also need the balloon catheter and puncture needle and the pressure monitoring device. After disinfection and dripping, we begin with the procedure, and the operation can be simply divided into 4 aspects. First, percutaneous puncture of the foramen. Second, the insertion of the balloon catheter. Third, injection of the contrast agent to perform the compression force removal of the device, and followed by local comprehension for hemostasis. Next, I will describe these steps in detail. The first step is to puncture. Following the principle of Hartel anterior approach, the puncture site is located laterally 2.5 to 3 centimeter from the corner of the moss. In the coronal plane, we aimed towards the medial side of the pupil. In the sagittal plane, we aimed at about 2 to 3 centimeter in front of the external auditory meatus. The intersection of these 2 directions is the location of the foramen. While percutaneous scan, the finger of another hand should be placed inside the moss, providing a gentle counter pressure against the needle to prevent penetrating the oral mucosa. Since the oral cavity is not disinfected, we need to change our gloves after completing the puncture. Excessive depths or during the puncture may introduce potential complications. When performing the puncture under lateral fluoroscopic guidance, we often use several bony landmarks, which we have listed as 1, 2, 3, right? However, my personal favorite landmark at present is another one, right? The junction between the posterior margin of the lateral pterygoid plate and the skull base. This corresponds quite accurately to the location of the foramen. We can see that although the distance between the mandibular condyle and the foramen wires, the foramen is basically located at the junction of the pterygoid plate and the skull base. Certainly, we can also perform foramen puncture under AP fluoroscopy. Usually, it requires us to rotate the C-arm about 20 degrees towards the affected side and about 40 degrees caudally. Because of the initial learning experience, we did not regularly perform an AP fluoroscopy, but for inexperienced surgeons, this could be a good choice. We will also demonstrate this laterally, all right? The second step is to insert the balloon caster. During the process, you may feel slightly resistance. Excessive resistance usually indicates an incorrect position. About the depth of the catheter, generally it should go past the clivus, but within 1 centimeter. When the catheter is in the correct position, it should show a slightest curve, similarly to a fishing rod shape, right? We often encounter such problems when inserting the balloon caster. There is a strong resistance, making it difficult to advance it into a microscope. And sometimes the caster the caster even be folded, right? In such cases, we need to withdraw the caster and adjust the position of the needle tip as the foramen until the caster successfully enters microscope. This is these 3 images are from the previous 3 cases after adjustment. Generally, the caster will show a curved shape towards the posterior fossa. And once inside the microscope, there will be no further resistance when advancing the balloon caster. The next step is injection of the contrast agent and compress the trigeminal ganglion. We summarized the key point of this procedure as apply suitable pressure for a certain period of time at the correct position. A pear-shaped morphology is an indicator of correct balloon positioning. In our cases, the mean balloon volume was 0.65 milliliter, with a minimum of 0.3 milliliter and a maximum of 1 milliliter. Our current practice involves a compression duration within 2 minutes, with the peak pressure around 170 kilopascals. As compression proceeded, the pressure gradually decreases and eventually stabilized at a constant value, which we refer to as the stable pressure. The median stable pressure is 138. Excessive pressure or compression duration may lead to severe facial numbness and other complications, whereas insufficient pressure or compression time may not guarantee this therapeutic uh, efficacy. Therefore, this is crucial to finally balance the relationship between the balloon shape, compression time, and the pressure. When the balloon is in the correct position, it will take on a pear shape. However, in an incorrect position, it can appear in various forms, round, oval, or even irregular shapes. In such cases, as we mentioned earlier, we need to withdraw the balloon caster first and adjust the position of the puncture needle at the foramen up and repeat the puncture procedure until it enters the Michael's cave. There are also problems we may encounter occasionally. The balloon was in the epidural space, partially within Michael's cave and partially subdural, or the balloon was in the subdural space within the temporal lobe. These are all those things we need to pay attention to during the operation. And the last step, the puncture needle and the caster were withdrawn together, and we applied pressures towards the base of the skull for hemostasis. Some patients may experience facial hematoma postoperatively. We can use cold compresses to alleviate the situation. And now let's look at several cases. This is the first one. The caster was initially positioned too high. During the operation, we adjusted by elevating the puncture needle and increasing the insertion angle. After adjustment, the caster position was significantly lower than before, and it was successfully advanced into Michael's cave. And in the second cases, the caster was initially positioned too low. Under such circumstances, we adjusted by lowering the angle of the puncture needle, thereby creating a channel for the caster to advance upward and finally successfully placed it into the Michael's cave. The adjustment method in case 1 and case 2 can solve problems encountered in many cases by elevating or lowering the puncture needle and appropriate surgical path is established to allow the caster to enter Michael's cave. This show the intraoperative adjustment process for our third cases. We observed wires configuration during the manipulation, including different caster position and the balloon shapes. At one point, a dumbbell shape appeared, indicating correct positioning. This is the gold standard for this procedure. When identification is difficult, the caster can be advanced slightly deeper. If it passed through the pars trigeminus and forms a dumbbell shape, we can confirm that it is located within Michael's cave. Case 4 and 5 demonstrate unusual morphologies of Michael's cave that we occasionally encounter during surgery. They may not be pear-shaped, but instead appear stripped shaped. In such cases, we can also advance the catheter deeper, and after passing the porous trigeminus, it will still show a dumbbell shape or a similar bulging appearance. Occasionally, Michael's cave can be quite large. In such cases, the balloon may not remain stable during the compression. We therefore need to advance the catheter deeper until a dumbbell shape is achieved. This is also presents that same condition with a large Michael's cave. We find it difficult to confirm. We can advance the catheter more deeper, right? And dumbbell shape morphology may appear. In addition, we sometimes encounter this pseudo pear shape intraoperatively, which requires carefully judgment. It may appear pear-shaped, but its morphology changes gradually with per-land compression. Further, there is usually a resistance when attempting to advance the catheter further. In such cases, the catheter is not within the Michael's cave, and adjustment is necessary. The sign of the catheter entering Michael's cave is, as we just mentioned, it can pass the porous trigeminus, and there should be no resistance when advancing the further posteriorly. We also have attempted balloon compression for secondary trigeminal neuralgia. Some patients are elderly and not suitable for craniotomy. In our experience, although Michael's cave may be occupied by lesions, a pear-shaped appearance can be still achieved in the majority of the cases. Okay, this is next is efficacy assessment. This is the data that was first reported by Professor Mullen, and below is a set of data from our hospital. Generally, the rate of immediate pain relief and continuous pain relief after PBC are satisfactory. Regarding complication, mild to moderate numbness in all distribution of trigeminal nerve and master muscle weakness could be observed in nearly 100% of patients, but the majority of these cases are reversible. Other complications are relatively rare. Particular attention should be given to the trigeminal cardiac reflex. During pulmonary puncturing, or as the balloon begins to inflate, the majority of patients would experience a significant decrease in heart rate, and in some cases, cardiac arrest may occur, followed by a reflexive increase in the blood pressure and heart rate. We can see the cardiac arrest occurred in about 4% of the patient in our retrospective study. So atropine and antihypertensive medication should be prepared. This is also something we will need to emphasize to the anesthesia doctor during the surgery. That's all what I want to share today. Okay, thank you.
By way of introduction, I'm a neurosurgeon working in Manchester in the United Kingdom. I've been treating trigeminal neuralgia surgically for over 20 years. Although PBC is a technique I've only adopted in the last 5 months, and I'll explain more shortly. Just by way of introduction, I thought I'd summarize our approach to the surgical management of trigeminal neuralgia, which I'm sure most of you will be very familiar with. We looked at our surgical results a few years ago in a paper that was published, and did a study to understand which factors influenced our choice of surgical treatment for trigeminal neuralgia. And in particular, we wanted to look at the outcomes of both microvascular decompression and the percutaneous procedure that we carried out at that time, which was glycerol injections. And importantly, try to understand predictors of both success and recurrence of trigeminal neuralgia. So we collected data, both demographic and radiological data about MR findings, in particular vascular compression. We collected data about previous procedures and then looked at outcomes, both including complications and recurrence of neuralgia. We defined outcomes according to the BNI pain scale, and also looked at recurrence over a 4-year follow-up period. And over roughly 18 months, we collected 71 patients who had 79 procedures. 2/3 of them were microvascular decompression, and about a third were percutaneous glycerol injections. You'll see that these results largely mirror what is published in the literature. Microvascular decompressions achieve pain relief in between 90 and 95% of cases, with a relatively low recurrence rate. Whereas with glycerol injections, we were achieving fewer complete pain reliefs, although overall, over 85% of patients did have some improvement from their percutaneous glycerol injection. But overall, we concluded, as is well published, that MVD performed significantly better, both in terms of initial success and recurrence rate. And this Kaplan-Meier curve just defines what the recurrence rates are over the 4 years worth of follow-up. Overall, there was a relatively high recurrence rate amongst the glycerol injection group. So looking back on this cohort, factors which influenced our treatment choice towards percutaneous glycerol injections were when patients had had a previous failed MVD or had multiple sclerosis with secondary trigeminal neuralgia, whereas the presence of neurovascular conflict on MR scan inclined us towards a microvascular decompression. MR, as I'm sure you will all be aware, is now very sensitive for detecting neurovascular conflict. And when it came to predicting recurrence, the type of intervention mattered most, as in it was higher in glycerol injections, but the failure rate in MVD tended to be associated with those who had multiple sclerosis and where we didn't encounter vascular conflict at the time of surgery. So this has led us to favor microvascular decompression for most patients with trigeminal neuralgia if an MR scan does demonstrate neurovascular conflict. It gives a higher success rate and lower recurrence, but we still use percutaneous procedures for patients with secondary trigeminal neuralgia, most commonly with MS, those who've had a failed MVD, and in older patients or those with significant comorbidities. And overall, we have a fairly low threshold to suggest surgery for patients when medical therapy fails. So against this background, we have been using percutaneous balloon compressions in Manchester for the past 6 months. Just to give you a little bit of background, we'd been using glycerol injections in our unit, and it's widely used within the UK. But there is only one sole manufacturer in the UK for the National Health Service, and their manufacturing process broke about 12 months ago. So there are a large group of surgeons treating trigeminal neuralgia with glycerol injections who've had to look elsewhere. And I'm very pleased that we've come across the SYM PBC kit, and I'm going to describe our first 6 months of treating trigeminal neuralgia with PBC. So in that time, we've treated 25 patients. I recognise we're nowhere near the large numbers of Dr. Guo, but it's been very interesting listening to his talk, because already I'm seeing very similar trends in how we manage this and the intraoperative nuances. The The early cohort is of 18 patients, which is the group I'm going to present our results on. The most recent 7 patients, we don't have outcomes to share with you just yet. The majority of these patients had primary trigeminal neuralgia with or without neurovascular conflict, but we did also have secondary trigeminal neuralgia in this middle group, and we've had a few patients who've had persistent trigeminal neuralgia after a failed microvascular decompression. Overall, our pain relief rate in this cohort has been 82%. It is slightly higher in the group who have typical trigeminal neuralgia as opposed to atypical pain, although this difference was not statistically significant. Looking at BNI scores, the majority of patients were off medication, so overall we had 76% who were able to come off all medication after their balloon compressions, but then another 6% who remained on medication but had better pain control. Overall, we had a failure rate of 17% where there was no meaningful benefit. So coming on then to the key factor in achieving a successful PVC, which appears to be the shape of the balloon when you inflate it, and looking for that typical pear shape that Dr. Guo has described, and correlating that with the success of the procedures. Overall, we can see that when we are getting a pear shape, we're getting good pain relief. Having said that, we've had some pain relief in oval or dumbbell shaped balloons. We haven't found any statistically significant difference between the balloon shape and the pain outcome, but as you'll see from this table here, there is a larger grouping of successful BNI outcomes with typical or atypical pear shapes. In terms of balloon pressures used, recognizing these are still small numbers, but we're trying to err on the lower side of balloon pressure, so between 160 and 180 kilopascals. We try and maintain the initial pressure throughout the 90 seconds of inflation, and our compression time really for every single case has been 90 seconds. Looking at complications, our facial numbness rates have been lower than have been described elsewhere. We've only had 3/4 of our patients develop facial numbness, but a couple of them have also developed motor dysfunction of their trigeminal nerve. In association with the facial numbness, 1/4 of our patients have also had some eye irritation related to the loss of sensation. And then correlating whether the presence of facial numbness sits with better pain relief, there is a trend towards better pain relief if you do have numbness present. In other words, in this group here of patients who have numbness present, 91% of them did have pain relief, which of course means that there are a small number who have numbness but do not have pain relief. And again, correlating numbness with the shape of the balloon, there is no obvious significant association with the rate of numbness based on different balloon shapes, although it is difficult to come to any statistical significant test with the relatively small numbers that we've had thus far. So what do we mean by these typical and atypical pear shapes? Well, very much like Dr. Guo's presentation, you can see the typical pear shape of the balloon filling Meckel's cave, and the neck of the pear then being the balloon inflating within the porous trigeminus. These atypical pear shapes lower down, you really only see a very small neck of the pair emerging, and perhaps that's a reflection that they could be inserted a little further, but this is all part of our learning. We've had some cases where there is no hint of a neck to the pair, so we've had an oval shape, and we'll talk more about this particular case in a moment, but this is probably beyond the porous trigeminus sitting within the prepontine cistern. And then we've also had the dumbbell shape that Dr. Guo's described, where you get a waist at the porous trigeminus with part of the balloon within the posterior fossa. So just coming on to a few cases that we've had particular learning from. The model case, which I think we all want to see, is exemplified by this particular patient, who is a 48-year-old woman with idiopathic trigeminal neuralgia, definitely has no neurovascular conflict on MR scan. She was very well controlled with carbamazepine, but unfortunately it led to profound hyponatremia. She also developed pancytopenia and neutropenia. And so we really struggled to control her pain on alternative medication, and she was on a cocktail of drugs, including lamotrigine, oxcarbazepine, and pregabalin. So she elected for a PBC. The puncture needle was inserted as per Dr. Guo's description through the foramen ovale. The dilators were passed up to the 2 millimeters beyond the clival line. Then the balloon catheter was inserted. I love the description of it looking like a fishing rod, but I echo what Dr. Guo said, that as the balloon catheter is passed up through Meckel's cave, just as it enters the porous trigeminus, it curves slightly inferiorly, and that's the ideal finishing point for the tip of the catheter. You then inflate the balloon, and this balloon inflated with 0.7 mils of contrast, and we inflated to 160 kilopascals, and we maintained that pressure throughout 90 seconds, and this was the X-ray at the end of 90 seconds. One thing that has definitely struck me about percutaneous balloon compressions is there is immediate pain relief. This is distinct to glycerol injections, where often pain relief becomes evident over several days, sometimes as much as a week or two. But in the recovery room, we have had so many patients who've had a PBC saying immediately that their trigeminal neuralgia is gone. And this was the case for this woman. And when I reviewed her a few weeks ago, she was off all her medication. She did have some mild V2 numbness, but this was already improving in the 6 weeks since the procedure. A very satisfactory outcome. But we've had our challenges, and this is partly due to the learning curve associated with it. And I think hearing Dr. Guo's tips on this has already been very helpful to me. But I'll talk you through this particular case, which is a 70-year-old man who's got secondary trigeminal neuralgia from his multiple sclerosis. And we carried out, he was one of our very first patients, in fact, 6 months ago, where we carried out a PBC. And this was the first position that we got, which we felt was probably too far in and represented inflation of the balloon in the prepontine cistern. We also were unable to maintain a pressure above 100 kilopascals, telling us that we weren't in the correct position. So we withdrew the catheter, but got a very atypical shape. And I wonder if this was perhaps subdural. We were able to maintain a pressure of 165 kilopascals for 90 seconds, but he had absolutely no improvement in his pain. He didn't get any numbness either. So really, it didn't feel like we were ever in Meckel's cave in a way that was going to improve his pain. So he returned for a second procedure last month. And again, we struggled to obtain a pair procedure. We tried various alterations in the trajectory and the distance in which we inserted the puncture needle and the balloon catheter, and we were unable to either replicate the pear shape or indeed maintain a pressure of over 100 kilopascals despite inflating the balloon to a full 1 milliliter. Eventually, we settled for this particular position and inflated the balloon, but it wouldn't maintain above 100 kilopascals, and the stable pressure was close to 70 kilopascals. Looking back at his MR scan, he does have a particularly large Meckel's cave, and I think this is probably one of these cases where, because of the size of the Meckel's cave, one isn't able to get the pressure within the balloon up to the required levels, and perhaps this is a case where we should be aiming for a dumbbell type inflation to compress the nerve in the porous trigeminus. There are also difficulties, I think, in sometimes cannulating the foramen ovale. This is another gentleman with secondary trigeminal neuralgia who's had several previous glycerol injections, but it has had a recent recurrence of his pain. We've never had any issue cannulating the foramen ovale with the needle that we use for the glycerol injection, and this X-ray demonstrates this needle. However, getting the puncture needle into the foramen proved very difficult. What we did find helpful was passing up the fine dilating needle within the puncture needle, because this is more easy to insert into the foramen ovale, and you can be more certain that you're in the correct space, even if the puncture needle can't adequately advance into the proximal part of the foramen ovale. So by using the dilators, we were able to satisfactorily get into the foramen, and he experienced a really good immediate pain relief after his PBC. So I think this is a case of a narrow foramen. What we don't necessarily do, as Dr. Guo does, is carry out preoperative CTs to understand the anatomy of it. But perhaps if he has to come for any further PBC, that will be helpful to help us understand the anatomy of the foramen. So in conclusion, we've now had 6 months experience of PBC, and I must say I found it a straightforward technique to adopt. Now, this is on a background of having performed several hundred other percutaneous glycerol injections in my career, but the techniques I used for that were easily adaptable to PBC. I think that this particular kit is very well designed and easy to use. Already we're learning nuances of anatomy of Meckel's cave and the porous trigeminus and foramen ovale, and this does mean that you have to be adaptable in your positioning of the cannula and the balloon catheter. And as we're seeing, the balloon shape and volume is very variable, but again, it's a matter of learning what is acceptable and efficacious. Overall, I found that PBC is equivalent or probably better in terms of pain control than glycerol injection, but it is associated with a higher rate of numbness than we've experienced with a glycerol injection. However, it does appear that the high rate of numbness does equate to good pain relief. And that's all I have. Thank you.